Yeah. Sir, you can go live now.
Good afternoon, viewers. Welcome to Cancer Reach. Cancer Reach is initiated by Dr. Krishnamani, a renowned medical oncologist in Hyderabad. The main objective of this Cancer Reach is to spread awareness and help patients and their relatives to access the cancer treatment on right time. So, as every week we learn something new in cancer, this year I'm today we are here to learn about thyroid cancer. So, welcome, Dr. Krishnamani, sir.
Uh, Hello, thank you. Welcome to Cancer Reach. Cancer Reach, as you all know, is an initiative to spread awareness about cancer. And today, as you said, we'll be discussing about thyroid cancer.
Thank you very much, sir. Because viewers, if you are interested in any other cancers like lung cancer, breast cancer, ovarian cancer, gastric cancer, colorectal cancer, many cancers we have discussed in our past episodes. So you can refer to those videos if you want to learn more on that. Before getting into that, uh, Dr. Krishnamani sir, thank you very much for spending your time and sparing your valuable time to create awareness on these topics. Doctor, and can you please enlighten us, like, what exactly thyroid cancer is and how frequently you see cases in your real-time practice?
See, we all have a thyroid gland that produces the hormone called thyroid hormone or thyroxine. So this hormone is extremely important for many functions in our body. Okay. So now a cancer which starts in the thyroid gland is known as a thyroid cancer. Broadly, when you talk about thyroid cancer, you are talking about either papillary thyroid cancer, follicular thyroid cancer, or anaplastic thyroid cancer. Now, a lymphoma, a sarcoma, carcinoid tumor, anything can come in thyroid. Okay, those are cancers, but those are rare varieties of cancers which start in the thyroid gland. So when we talk about thyroid cancers, what we mean is we are talking about differentiated or de-differentiated cancers of the thyroid, which are follicular or papillary thyroid cancers, which are the two most common, and anaplastic, which is a very aggressive variety of thyroid cancer.
So, doctor, in a common people, when they found some swollen areas in the neck or any grown extra growth elements you see on the neck area, so can we suspect it is a thyroid cancer? Is every tumor in the thyroid is a cancerous?
So see, the thyroid is present somewhere here. Okay, so very commonly we hear the word called goiter.
Right.
Goiter means a swelling in the neck, which is due to a thyroid issue. Okay, so there are, because of the hormone excess, you can either have hypothyroidism, low thyroid, or high thyroid. Number one. So that is the hormonal part. If you test the blood, you will get to know the hormonal part. Goiter is a swelling in the neck, which is due to the enlargement of the thyroid gland and which usually moves during swallowing. So when you ask the patient to swallow like this, the swelling moves up and you can touch the lower border. That is a thyroid swelling, and those swellings are called goiters. Sometimes only it's a uniform enlargement. Sometimes only one particular part of or lobe may be enlarged. So that is sometimes called a nodule.
Nodules.
And also, you can have lymph nodes in the neck when the disease spreads to those lymph nodes. So a patient could come to you potentially with either a swelling in the neck or the swelling of the thyroid or swelling of the lymph nodes or uh, because of the uh, what do you say, invasion or the spread of the tumor to the adjacent organs. They can come with complaints like hoarseness of voice, difficulty swallowing, difficulty in breathing if it obstructs the trachea and the foot pipe and the windpipe, and or they can also come with an increase in the size of a pre-existing goiter. So they may say, I had a swelling here for the last 20 years. Now, for the last 6 months, it is growing very big. So then that should raise the suspicion of a cancer.
Okay.
So you have had a swelling for 20 years, 15 years. Now suddenly it is growing in size and it is causing all kinds of difficulties. Also, please understand Today, because we do routine imaging so commonly, we do ultrasound neck, ultrasound, CT scans as master health checkups for so many people. Because of this routine scans, even if patient doesn't have symptoms, you're identifying thyroid cancers.
Thyroid cancers.
So how you are going to identify is one, patients are asymptomatic and they get detected on routine scans. But that time when they detect those cancers, they are small because they are still not big to cause symptoms. Two, patients can present with the swelling of the neck or swelling of the lymph nodes. They can present with the rapid increase in the size swelling of the pre-existing goiter. They can present with symptoms in the form of hoarseness of voice, difficulty swallowing, and difficulty breathing. Or they can present with spread to other organs. If it spreads to the brain, they can present with fits or weakness. If it presents to the bone, they can present with bone pain. If it presents to the lung, they can present with breathing difficulty and cough. They can present with weight loss, loss of appetite in advanced cases. So this is how you will see patients coming to you with probable thyroid cancer.
And doctor, how frequently these cancers occurs in the society? Like how frequently you see the cases?
It is a common cancer. It is seen in women more than men. For every man, there are 3 women who will develop thyroid cancer. If you have one male who develops thyroid cancer, you'll have 3 women who will develop thyroid cancer, and commonly between the ages of 30 to 40.
30 to 40.
So it's not a disease of the too elderly, and it is not a disease which is seen in men. Actually, it is seen on the contrary in women.
What are the common risk factors for to develop this cancer, doctor?
So somebody who has thyroid cancer in the families has an increased risk. A twin has an increased risk. Uh, if you have had radiation to the neck for some other reason, you have an increased risk of thyroid cancer. And textbooks also obviously mention patients of atomic bomb survivors like Hiroshima, Nagasaki, Chernobyl, nuclear disasters have a higher risk of thyroid cancer. So commonly for us, it is either familial, it runs in family, or somebody who has received radiation in the past is at risk for thyroid cancer.
Got it, doctor. Because radiation exposure or any other
That
pre-existing history in the
causes the
family
cells to mutate and leads to development of cancer.
cancer. And doctor, how can we differentiate like sometimes head and neck cancers that happen swellings, and because neck also it's part of your front portion and back portion. Like how do you differentiate these head and neck cancers and thyroid cancers separately?
So when you examine, it is pretty clear. Okay, if you head and neck cancer is a whole set. You are talking about lip cancer, you're talking about
Everything.
tongue cancer, you're talking about buccal mucosa in the inner part of the mouth, you're talking about palate cancer. Okay, you're talking about food pipe, upper part cancer, you're talking about windpipe, laryngeal cancers, you're talking about sinus cancers is developing these sinuses. So all these are head and neck cancers. They can present with an ulcer in the tongue or an ulcer in the mouth or lymph nodes. Thyroid cancer, on the contrary, presents with a swelling in the midline, plus or minus swelling of the cervical nodes, that is, in lymph nodes in the neck.
So what are the different types of thyroid cancers?
The most common types of thyroid cancer are papillary thyroid cancer, follicular thyroid cancer, and anaplastic thyroid cancer. The commonest is papillary and follicular. These are called dedifferentiated thyroid cancers. They have a good prognosis.
Okay.
They have a good prognosis. Surgery is the main part of the treatment. And after surgery, some patients, based on the risk, are advised radioiodine treatment. So, bottom line is, it's a disease of the young, predominantly women. Papillary and follicular are common types. They are good prognosis. Surgery is the mainstay of treatment if you diagnose, and followed by radioiodine in some patients.
Doctor, if anybody found a swelling in the neck or swelling in the thyroid region, uh, where actually they have to start their treatment, like whom they have to approach first and how they reach to you in the end stage, like for cancer treatment and all. Because in the common society, what is happening, there's a misconception happen. A tumor, it need not be cancer always. A cancer cannot be detected as a tumor. So there is some misunderstanding in the common people. So when you have identified some swelling in the area, like how to suspect them as a cancer and how to reach your doctor early. So is there any guidelines for it for screening or like any diagnostic protocols to take care?
Once you are suspicious of a diagnosis of thyroid cancer, you will first undergo a hormonal test, thyroid hormone test. You will first undergo a neck ultrasound. The neck ultrasound, the radiologist will look at the thyroid and tell you whether any nodule is there and how suspicious it is. They give a scoring of 0 to 5.
Right.
It's called TIRADS scoring. Like for breast, we give BIRADS, breast imaging. This is called thyroid imaging. The higher the score, the higher the chances of it being malignant. And if the score is high, the radiologist will advise for an FNAC. It's a needle test, fine needle aspiration cytology. So they'll put a needle into the thyroid nodule, which is suspicious, and send it. And if you see cancer cells in that, you are diagnosed as having thyroid cancer. Obviously, you will examine to see if it has spread to the nearby lymph nodes. You will do an X-ray or CT scan to see if it has spread to the lungs, etc. So this is the first step. An
Okay.
ultrasound of the neck, hormonal evaluation, FNAC of the suspicious nodule.
Yes, doctor. And doctor, because in our general practice, like when there is any throat issue, any change in the voice, any difficulty in the swallowings, we directly approach to ENT first. Because cancer specialist doctor availability in the rural areas, and if you take tier 2 cities, tier 2 cities is very limited. So like my intention, like my question is that, like, when to reach the oncologist to delay further and to avoid the risk of progression and to increase the lifetime.
So the ENT people are very qualified to pick up any of these cancers. So once they raise an alarm, the patient should immediately meet an oncologist. Or even after meeting your ENT doctor or anybody for that, symptoms are not improving, seek another referral or meet an oncologist just to rule out. If you don't have cancer, well and good. So symptoms not improving, or if he or she is referred directly by the ENT physician, that entails that that patient is going to be seen by a surgical oncologist or a medical oncologist.
And doctor, just a few minutes before you said surgery is the mainstream of treatment for this thyroid cancers. Apart from surgery, is there any other modalities to treat thyroid cancers?
So when you talk about papillary and thyroid follicular cancers, if for the disease, when it is diagnosed, surgery is the mainstay of treatment. In the surgery, they are going to do a total or a near total thyroidectomy, that is removal of the thyroid gland. They will also dissect the lymph nodes to see if the disease has spread. After that, you are in a particular risk, low risk or intermediate risk or high risk. For intermediate and high risk people, generally, what we do is we do radio iodine scan. And in that, if there is uptake, radio iodine uptake, those patients undergo radio iodine ablation. That is not radiation, they are given radio iodine so that wherever the radio iodine is being picked up in the body, that is killed. By this way, you are killing any remnant cells in the body which are cancerous.
Got it, doctor. And doctor, how long this treatment goes on? Like how long patient has to be on the treatment for this?
So the patient is usually seen in a center which has radioiodine therapy. This is usually done by people who are nuclear medicine specialists, like doctors who read PET CT scans, to put it very simple. So the patient will be under their follow-up. After the scan, they'll be doing tests like TSH, thyroglobulin, etc. If the tests are in normal range, they are kept under regular follow-up. A rise in the thyroglobulin indicates probable recurrence, and then they will be evaluated again. Many a times, patients will require multiple sessions of radioiodine ablation so that whatever remaining cancer cells are there are completely knocked off.
Doctor, are there any chances of complete cure in this thyroid cancer?
Definitely. Many patients do achieve cure. That's why I say it's a very, very good disease. It is one disease, even if it has spread to other organs, you will still do thyroid surgery because somebody has a thyroid cancer here and it has spread to the lungs. Generally, what would we say? It is stage 4. What is the point of surgery? No. In thyroid cancer, if you don't remove the thyroid gland just because it is stage 4 and give radioiodine, all the iodine will be taken by the thyroid because thyroid eats iodine.
Yes, sir.
So even if it is stage 4 or if it is spread to the lung, you are going to operate here. And after that, give radioiodine ablation to kill the remaining cells in the lung or the other parts of the body. That's why even advanced cancers have good prognosis. Even in advanced cancers, primary surgery to the thyroid is advocated.
Thank you, doctor. Because as we discussed in the previous sessions for different cancers, like when a cancer reached to the stage 4 disease
Correct.
and surgery cannot be done at all, and they were put on the chemotherapy or any targeted therapies and all, surgery was not recommended at all. But whereas thyroid, it's totally different, what I understood now.
Definitely.
So even in stage 4 disease, you need to go for surgery and then followed by medications like chemotherapy, targeted therapy, or any other things. Great, doctor. And doctor, are there any link between smoking, alcohol consumption for this thyroid cancer development? Because
Not
you said it's a
very clear.
hormonal changes was the main reason for it.
Not very clear cut.
Not very clear. Cut.
There's no clear
And
association.
yeah, one can how to reduce the risk of developing these thyroid cancers.
See, if you have a family risk, maybe you can have a routine screening. If you have been exposed to radiation, maybe you have a routine screening. I mean, you can have an ultrasound of the neck or just have a close look at your symptoms or look at your neck. If there is any subtle change, please go and visit your doctor. Not that you should be scared every day, but if you feel there is a swelling, just go and take medical advice or attention. That's all. There is no routine screening or blood test available.
So unlike other cancers,
Ovarian
thyroid cancer. Yes,
Sorry,
sir.
in breast we have mammogram. In cervix we have pap smears for
Correct.
screening. You don't have it in thyroid.
In thyroid. So screening is not recommended in this. So whenever you identified some symptoms, difficulties, or signs, immediately we need to take attention and approach the doctor.
Also, you should understand these symptoms are not specific for thyroid cancer.
Thyroid cancers. Of course, in today, doctor, you cannot neglect any abnormality what you found in the body. It's better to take immediate action to address the issue at the early stage.
So, if you have a neck swelling due to any other cause, also it could mimic like a thyroid cancer. Hoarseness of voice can be due to common cold also. So, everything is not thyroid cancer.
Thank you very much, doctor, because it was really an interesting session and valuable information which you have shared.
I
And
would like
any
to
message you could,
correct.
yes,
I would
any
like
message?
to add one thing here.
Yes, sir.
So, there's a variety of thyroid which we did not discuss, which is called the anaplastic thyroid cancer. So all now we spoke about papillary and follicular. Anaplastic is a very aggressive variant, usually occurs in the elderly people. There is a rapid growth in the tumor. It spreads to the nearby organs and it obstructs your airway, breathing. So that's why when somebody has a rapid neck growth and affecting their airway, we should think of anaplastic thyroid cancer. Our first job is to secure the airway. That their breathing should be fine. Then you will biopsy or you will do an FNA, you will do a PET CT, look at the stage, what is it, whether it is anaplastic or not, and then based on that, you will go do your treatment. In anaplastic, you either operate. After operation, we give radiation plus chemo. If you cannot operate, we give targeted therapy tablets. If they have certain mutations called BRAF. Even if that cannot be given, sometimes we give immunotherapy or chemotherapy. But overall, compared to papillary and follicular, anaplastic is a very bad and aggressive variant. And finally, coming to papillary and follicular, some patients will eventually fail your radioiodine treatment. They are called radioiodine refractory thyroid cancer. So those patients will come to the medical oncologist. They will require systemic treatment in the form of tablets like either lenvatinib or sorafenib, etc. All these patients' tumors samples has to be sent for molecular testing. Because in thyroid cancers, we are finding many molecular alterations like BRAF, RAS, NTRK. And for each of these molecular problems, you have a specific drug available. So chemo is not given. You give specific targeted therapy. You send the tumor for molecular analysis in papillary and follicular who have failed radioiodine treatment or which are called radioiodine refractory.
Got it, sir.
Right.
So, I mean, a treatment part, like if they are not responding to the previous lines of therapy, and now definitely they need a long-run therapy along with the
Then the
target
medical oncologist role comes, and it is not chemotherapy in follicular and papillary. It is tablets or tyrosine kinase inhibitors
inhibitors.
based on
Targeted.
molecular marking.
Great, doctor. And doctor, any final message for your audience on this thyroid cancer?
So thyroid is not a rare cancer. It is seen in the young, especially the females. A painless swelling in the neck or a sudden increase in your neck swelling should prompt you to take medical attention. Or if you find something suspicious on an ultrasound, please get an FNAC done as guided by your doctor. If it turns out as a thyroid cancer, papillary and follicular are the common types, and surgery is usually the mainstay of treatment. This is and the prognosis is usually good. We need not be alarmed about it. And these patients need to be on regular follow-up with TSH and thyroglobulin levels. And they will always be on hormone replacement, because once you remove the thyroid, there is no thyroxine. So forever they'll be on thyroid hormone tablets to suppress the TSH.
Yes, yes. Clear, doctor. So, I mean, unlike the other cancers, it's not a dangerous cancer. It can be cured, and there is a possibilities of long survival with this. And treatment's also very easy.
Correct.
I mean, manageable, not like chemotherapy or any other difficult treatments are required for this.
Yeah.
And of course, as you rightly said, there is no screening, but once anybody identified any signs and symptoms, they need to take attention and approach to your nearby doctor to take further action. Thank you very much, doctor. That was really great, informative discussion. And we thank you very much for attending this session and enlightening us on this thyroid cancer.
Thank you so much. Thank you.
Let's catch up with another interesting new cancer discussion in next week or for the week, doctor. Thank you so much.
Thank you.
Have a great day, sir.